injure the patient. Okay, so with the cassette holder, you can use this. You just slide it under the pad, and then it will hold the cassette in place. But if it starts to tilt like this, you may need to use some tape or something because you want your cassette perpendicular to the table, not leaning in like this. But if you do it like this, it's going to look slightly oblique on the image. But look what happens when you turn the light on. See how it almost looks like her anatomy is over the top of the cassette? So if you're going to use this kind of holder, you either need to bring the cassette up a little bit or just use the smaller pad. You might be better off just using the smaller pad. So I can either mark this so it says left side up, because apparently all my arrow markers have disappeared, but you could write left side up, or we also have a decubitus marker here. So I can have this on the bottom, right side down, right lateral decubitus. But what you don't want to do is put the right lateral decubitus on the left side of the body, ever. Never mark the right side with the left marker, never mark the left side with the right marker. So it doesn't matter if you do this side or this side, but make sure you have the correct side marker on the correct side of the body. So this is easier because it's up, or I can just simply take my right marker. If you're doing the chest, I would mark the upper part so it doesn't get in the lung field. Right lateral decub, that indicates that's the right side down. Okay, so what projection is this?
A PA.
Yeah. The one thing we don't like about PA, it isn't as stable. I've got the patient pretty close to the edge of the table. With real patients, you have to be very careful because if they're not stable, they could roll off. This is not going to be enough to support them, and they could roll right off the table. So you have to be careful about that. When I position the cassette, I want to make sure that I've got it above the apex. So to start with, I'm going to have her arm down by her side so I can see where the shoulder is. And then most people have a tendency to do this, so you want to bring their head up. So basically, you're putting the cassette up by the chin at the top, and then look at where the iliac crest is here. So the bottom of the cassette should be by the iliac crest, the top of the cassette's by the chin. Because just like we did in PA chest, you're not going to have lungs that go below the iliac crest, right? So if that bottom of the cassette is at the top of the iliac crest, then you know you've got your lung on there. Okay, so you have to make sure she is nice and lateral to make a true PA. So I want her close to the film here, and then make sure that this is like this, that she's not rolled out or rolled in towards the cassette, because people will tend to do that. They'll roll in instead of scoot in. So make sure this is nice and straight, perpendicular to the table. Did I hurt you, or did you think I was going to throw you off the table?
I thought you were going to throw me
No,
off
I'm
the
right
table.
here. I'll catch you, girl. Hurt you and all. I'll catch you. Okay, so see how her one arm is here? That's another thing that can get pinched. So make sure you really get the arms up out of the way so you can move the cassette where you need to. So this is all the stuff you have to look at. You don't want to pinch their skin. You don't want to pinch their breast. You don't want to hurt them in any way. So be careful with your equipment. Okay, now you're going to put the central ray right at the mid-sagittal plane. Okay, and then at the level of T7, just like we do on any chest x-ray. Okay, now open the collimation up real high or real large. You shouldn't see light go on above the cassette. See how you can see light on me? So you want to collimate down so you're barely seeing the light and you're barely seeing the soft tissue on the cassette here. See that? Now notice how the light's skimming the bottom pad? You need that. If you collimate so closely that you don't see light on the pad, then the body that's sinking into the pad is not going to be visualized on the image. So as long as you're centered and you've got your 14 by 17 collimation, you should be fine. Questions?
That pad should be, I mean, it's necessary if we don't put the pillow. supposed to be use the
This
pen.
part here,
Yeah.
it's uncomfortable for the patient because they're having to lay with their head all crooked. So that's why I let her keep her pillow. Now one more thing, I think I did this already, but let me make sure. Don't lay it on the table. You want to, see I didn't. You want to increase your SID as much as possible by bringing the table. Now when we're doing cross-table extremities, and you always had to remember to bring the table away from the tube, it's the same principle. The greater the distance, the less the magnification. You have a question, or are you just resting?
Oh, no. I'm just
Was that bottom right on the iliac crest or on top?
It's right at it.
Oh, okay. You
In
said
fact,
on
she's
the
small
shape.
enough. She could probably, we could table and collimate inside to side a little bit, yeah. Because she doesn't need the full 17 inches. Probably maybe you do because you're taller, or Tal. And then where's my shield? So just like any chest X-ray, take a breath in, blow it out, take a breath in, exposure. Now, how long does she have to stay like this?
5 minutes.
At least 5 minutes. And Erica's been a wealth of information today through some research she's doing for her class, for something that happened, I guess, at the hospital, huh? She said that they did one at 5 minutes. It didn't show the fluid. They waited 15 minutes, and then it showed the fluid. So it's at least 5 minutes. But you can see, if you get your patient laying on their side and then get all your tube and everything, it's going to be at least 5 minutes by the time you get around. It's actually making the exposure. Okay. Now, this is a PA projection. It's not as stable as the AP. If you wanted to do a right lateral decubitus in an AP, how could I accomplish that with this tube? Yeah, I'd have to have her lay on the table so her head's at this end. And you have that option. I'm going to show you today how to do decubes like this with the cassette and also with the gurney against the bucket, which is another way it's commonly done in the hospital.
No,
I'm so happy we have this fancy gurney.
that's all right. Decubitus.
So it's going to be your option. Your card is going to say right lateral decubitus or left lateral decubitus chest. How you get to that point, it doesn't matter to
So
me.
PA or AP?
Yeah, but it better be a right lateral or left lateral decubitus. If it's supposed to be right lateral, don't lay them on their left side, because that'll be completely wrong. Now on the abdomen, it's only going to say decubitus, because you're supposed to know which side to do, which is that.
No.
Because we don't do a right with normal radiography. We'll do it later when we get to PE. Okay, so I've done her right side. Now I'm going to do her left side. So go ahead and flip over and face the machine for me. Okay, now see how she's got a pretty big OID here? So I want her to scoot back, so scoot your hip and your shoulders back. So don't let her roll back. She's got to shift her whole body weight so she still stays lateral here. See that? Okay, I'm going to bring her arm down to make sure that I've got the cassette at the apex. I can see her cervical prominence, so this needs to go up. And that always happens. For some reason, when you flip somebody from one side to the next, they always move up about 4 or 5 inches. No, it's okay. I mean, it happens all the time. You want to make sure and get this arm up out of the way. Don't leave it down in front of the patient's lungs. And then this arm could either stay here, or you could just go ahead and bring it up to get it out of the way so you can see your anatomy a little better. Okay, so now since this is her, here it is, right side, I'm just going to go ahead and use the right marker and the up. Now see how this makes her a little more stable? Again, be very careful though. Your patients that aren't real, strong, like if they've had a stroke or something and they can't hold themselves up, don't put them on the edge of the table like this. Or at least when you've got them like this, move the gurney over. Put it there to give them some, lock the gurney so if they do fall back, they'll land on the gurney and not on the floor. Every year I have somebody drop a patient on the floor. And sometimes it's very serious. Skull fractures, hip fractures. And it's because of their negligence. And you don't want that to happen to your patient. Okay, so that's the left lateral. Any questions? All right, I'm going to move down to the abdomen. You could do PA or AP, but AP is probably more comfortable, especially with someone who's cathartic. But the thing is, if she was elderly and I was doing all these other x-rays with her head up here, I wouldn't turn her around and make her go with her head down here. I would have to adapt to how she's laying. That's why you need to know how to do both ways. Okay, stay on your side, Erica. Don't move. Okay, so now I'm going to do the decub of the abdomen, which he's already in this position. So I've got my grits set. Okay, where do I center at for a decubitus?
Abdomen,
Mm-hmm.
2 inches.
2 inches above. So
the-
2 of them are above the iliac crest, 1 is at the iliac crest. The supine is at, the upright and the decub is above.
Yes.
Because we're looking for air in the diaphragm. We're looking for air that's raised in the abdomen. So here's your iliac crest. So what we usually do for the 2-inch rules is use 3 fingers. So you put the line that you're palpating on this finger for me, and then I'm going to go 1, 2, 3. So this is where the other central ray should be on the other side of my other finger. You see it? So here's her iliac crest, 1, 2, 3. So here's the central ray. Okay. Now, earlier they've asked me when we were on the chest, if you're going to do a crosswise AP chest because it's a wide patient, would you do crosswise decub? And for some